You enter the clinic. Be it you are a busy doctor or a patient, you know the drill. 10-minute consult, a packed waiting room, and another patient presenting with severe lower back pain and sciatica. Today, we are going to give you a super reliable, structured framework for assessing these exact patients. We are unpacking the NICE NG59 guidelines for you. Why do two identical MRI scans lead to totally different surgical advice? Picture patient A. They are suffering from severe radiating leg pain, but someone just tells them, wait it out. Then you have got patient B who just has a minor backache getting rushed into surgery for an incidental disc bulge. It's wildly inconsistent, right? And honestly, it is incredibly frustrating for us. And it causes total confusion and unnecessary anxiety for our patients. So, to clear up this confusion, this explainer is going to cover the clinical inconsistency problem. It is called as the locked workstation model, the 3 passwords for surgery, the red flags, the NICE firewall, and finally, how to clearly communicate all these with our patient. Okay, section 1, the clinical inconsistency problem. Without a really solid structure system, we basically fall into a trap of extremes. On one hand, we risk over-treating the patient who just have non-specific back pain. And on the flip side, we end up under-treating folks who are actually suffering from severe debilitating nerve compression. Thankfully, NICE guidelines give us a clear step-by-step clinical decision pathway to prevent exactly this. Moving on to section 2, the locked workstation model. I absolutely love this concept. Think of surgical pathway for lumbar discectomy exactly like a locked computer workstation in your clinic. The default status, it is locked, and it stays safely locked to prevent rushed incorrect decision. While the option for surgery is exactly the same, it is securely locked away until you, the clinician, can enter the correct credentials. That brings us to section 3 passwords to surgery. So what are those credentials? Think of this sequence as your mental infographic mapping out for surgical clearance. You need 3 specific passwords. Password number 1. The MRI scan and the picture presented should have clear, ridiculous features. Imagine a patient David. He has severe function limiting left leg dominant sciatica. It is so bad, it literally stops him from sleeping or even taking his dog for a walk. Now, if his pain was just mild lower back without these severe left dominant symptoms, the password is wrong. Access denied. Now, for the second password, the imaging must and has to match the story perfectly. Imagine another patient, Sarah. Her MRI scan shows disc bulges. But look, we know these are often normal age-related changes, right? For the second password to actually work, her MRI scan must show a disc prolapse perfectly matching the exact dermatomal pattern of a clinical nerve root pain. And finally, third password, time. Imagine our patient has been suffering for weeks. You must explicitly document that their severe leg pain has persisted despite a reasonable documented trial of guideline-based conservative care. This documentation step is crucial. If all these 3 are positive, then boom, the workstation unlocks and elective discectomy now becomes totally a justifiable option. Alright, now let's move on to section 4. Red flags and emergencies. Obviously, we contrast uncomplicated sciatica with red flag situations. The rule changes entirely. In that case, wait and watch is completely thrown out of the window. This triggers an immediate emergency override of our lock system. No passwords required. Section 5. NICE firewall. Just like our clinic's IT system has firewall to block viruses, NICE guidelines have a firewall to block non-evidence-based pitfalls. These are options that might feel like doing something to a desperate patient, but actually carries higher risk and limited benefit outside of the research setting. The firewall strictly blocks spinal surgery for non-specific lower back pain alone and blocks routine disc replacement or fusion just for lower back pain, along with passive modalities and long-term opioid-based strategies. And finally, section 6, communicating with the patient. Let's talk about managing the intense patient anxiety when they get their MRI results back. We have been there. A patient sees a disc prolapse on a report and their anxiety absolutely skyrockets. Here is a great sample phrase you can use. A worrying scan alone does not automatically mean you need surgery. Explain to them that we weigh their symptoms, their function, and time alongside the imaging. We are treating the patient, not just blindly reacting to a picture of normal aging changes. The NICE guidelines heavily emphasize shared decision making. You want to empower your patient to look ahead using simple language. Ask yourself and your patient, how does this actually fit with NICE NG59, and what is likely going to happen over the next 6 to 12 months if we literally do nothing? This locked workstation model gives you the exact clarity you need to answer that confidently.